our multipolar catheter in the right atrium and coronary sinus to evaluate the electrogram activation sequence in 3 different examples of atrial flutter. So we could also call this segment a tale of 3 flutters. Here's flutter number 1 in a patient with prior coronary artery bypass surgery. Here's the 12-lead EKG, and let me zoom in on leads 2 and V1, because we reviewed before that if you see negative flutter waves in the inferior leads and positive flutter waves in V1, that is characteristic of counterclockwise right atrial flutter. And here you can also see the gradual downslope in the inferior leads, in lead 2 in this case, and the more rapid upstroke, very characteristic shape of typical counterclockwise right atrial flutter. And here are the electrograms in that first patient with a duodeca catheter looped around the right atrium with the tip in the coronary sinus, as I reviewed before. And now let's review the sequence of activation in the electrograms from which we're recording. You can see that the sequence of activation is duodeca 10 and then 9, 8, all the way down to 1, which anatomically speaking is a counterclockwise route around the right atrium and traveling out the coronary sinus, consistent with counterclockwise right atrial flutter. Here's just another catheter configuration that some people prefer for atrial flutter cases. Instead of using one catheter that loops around the right atrium and travels with the tip in the coronary sinus, people may use 2 separate catheters, one looping around the right atrium and the second in the coronary sinus. The one in the right atrium is often a 20-pole catheter, known as a halo catheter frequently. And then the one in the coronary sinus typically has 10 electrodes, and again it's advanced all the way into the coronary sinus with electrode pair 9-10 usually sitting at or near the interatrial septum. And so if you have counterclockwise typical flutter, you'll see that the wavefront propagation will travel around the right atrium, and you'll see the separate wavefront traveling out from right to left in the left atrium and in the coronary sinus. There's the cavotricuspid isthmus in green on the floor of the right atrium again. And notice in this scenario, you don't have any electrodes present on the floor of the right atrium. Some people just don't want to have a catheter there because they feel it may interfere with ablation catheter positioning and manipulation. But the downside is you can't record from your multipolar catheter anywhere near the isthmus, which you'll see in a little bit is the location where we'll perform ablation for typical flutter. Here's what the electrograms will look like when you have 2 catheters in the right atrium and the coronary sinus. In typical flutter, counterclockwise direction, you'll have the yellow arrow here, one wavefront traveling from 1920 all the way around to 1-2, and you can see that here in the electrograms. And then, of course, as the wavefront travels out the coronary sinus, you'll have a vector traveling from CS 910 out toward 1-2. But again, because we don't have any electrodes on the floor of the right atrium, you're going to see here a gap in time before the wavefront passes from electrode 1-2 in the halo catheter until it travels to 9-10 in the coronary sinus catheter. And that's reflected here in the absence of any signals between this part of the wavefront and this part of the wavefront. Let's move on to patient number 2, a patient who had prior mitral valve surgery. And if we zoom in on the inferior leads and in lead V1, you're going to see that this patient also has negative flutter waves in the inferior leads. Here I've shown lead AVF, and positive flutter waves in lead V1, again consistent with the possibility of counterclockwise right atrial flutter. In this case, however, we see electrograms that show a different story. This case involved 2 catheters, the halo catheter in the right atrium and the coronary sinus catheter in the coronary sinus. And again, to review and anatomically speaking where they're sitting, there's the dotted line showing the interatrial septum and the right atrium and the left atrium in this LAO view. And let's break this down and look at some electrodes at a time in small bits, because the picture overall, when you first look at it, can sometimes be confusing. Let's focus first on the coronary sinus catheter, which I've now enclosed in a brown rectangle. And you can see here the wavefront travels from electrode pair 910 to 78 and out to 12. And fluoroscopically speaking, that translates into a right to left direction, again consistent with the possibility of right atrial flutter. Now let's move on to the halo catheter, which is a little more complicated in this case. And let's break that down into two parts. First, if we look at halo 5 to halo 1, we can see the direction that that wavefront is moving, and I'll draw the green arrow corresponding to that wavefront direction, again consistent with counterclockwise right atrial flutter. But if we look at halo 6 through halo 10, we're going to see here the wavefront travels in the opposite direction, not what we saw in the previous case. And let's draw that arrow in here as well. And this shows a clockwise propagation wavefront here. And so this isn't as simple as a circuit traveling only in one direction or the other, because we have wavefronts traveling in two different directions in this case. We're going to review in the next module how we can further flesh out what's going on using entrainment maneuvers, but just looking at the sequence of activation in the halo catheter, we're now going to wonder if there's maybe either a focal tachycardia starting somewhere here on the lateral right atrial wall, or even a small circuit that involves the lateral part of the right atrium as well, sending wavefronts in two different directions. Let's turn our attention to flutter number 3 in patient number 3. This patient had a previous typical right atrial flutter ablation, but they come back with atrial flutter, and this is the bane of our existence when we think that we're seeing a recurrent arrhythmia that we thought we got rid of with a previous procedure. Here in lead 2, we see negative flutter waves, characteristic of counterclockwise right atrial flutter, and positive flutter waves in V1. And so we're worried about a recurrence of a flutter that was previously ablated. Here is a duodeca catheter wrapped around the lateral part of the right atrium and extending into the coronary sinus. And let's evaluate these electrograms, again in segments. First, if we look at duodeca 10 through 6, we can see that that wavefront direction is consistent with a counterclockwise right atrial flutter. If we look at duodeca 3 through 1, again, we can see travel from right to left in the coronary sinus, again consistent with counterclockwise right atrial flutter. However, if we look at duodeca 3 through 5, you see the opposite direction of wavefront, traveling in a clockwise direction across the medial floor of the right atrium, not consistent with counterclockwise right atrial flutter. And we're going to also review this case in the next module where we talk about entrainment to further flesh out what's going on.